Take.
Hi, I'm Sarah Tedeschi. I'm a rheumatologist at Brigham and Women's Hospital in Boston, and I'll be providing a brief clinical overview about calcium pyrophosphate crystal deposition disease, which we will call CPPD. CPPD is a form of crystalline arthritis that generally affects older adults. It's a symptomatic arthritis caused by calcium pyrophosphate crystals in joints. And I distinguish that this must be symptomatic because there are some patients that have manifestations of CPP crystals on imaging of the joints, but they don't have symptoms. And we do not include those patients when we talk about CPPD disease. CPPD is distinct from gout, which, as you know, is the other major type of crystalline arthritis. This disease is caused by a different kind of crystal, and it often affects different joints and actually has different presentations. Diagnosis of CPPD relies on a combination of symptoms, synovial fluid tests, and imaging tests. Synovial fluid will demonstrate calcium pyrophosphate crystals when examined with polarized light microscopy. And the calcium pyrophosphate crystals can be found within cells in patients who have acute inflammatory arthritis from CPPD, or they can be found outside of cells in patients who have chronic forms. Different imaging modalities can demonstrate the culprit crystals. On X-ray, we see evidence of chondrocalcinosis, which is calcifications in the meniscus or the hyaline cartilage. On ultrasound, we can see the calcific deposits in fibrocartilage here, or also in hyaline cartilage. And on CT scan, we can see calcifications in ligaments or other affected areas. CPPD manifests in multiple ways, and this is going to be an important point to remember for our discussion today. The most common way that CPPD manifests is an overlap with osteoarthritis. This means that patients with osteoarthritis and CPPD have osteoarthritis at unusual sites. For example, in the upper extremity, they may have osteoarthritis of the wrist or of the shoulder, which is uncommon in primary osteoarthritis. These patients may also have flares of acute inflammatory arthritis due to CPPD, which brings us to the next most common manifestation of this disease, which is an acute inflammatory crystalline arthritis caused by CPP crystals. This is characterized by the sudden onset of joint swelling and pain, often with warmth and redness of the affected joint or joints. Patients have limited range of motion in those joints, and this type of manifestation tends to resolve within several weeks after onset. A smaller group of patients has a chronic inflammatory arthritis caused by CPP crystals. This leads to chronic joint pain and swelling and or stiffness in the affected joints, and it's typically multiple joints involved. In fact, the pattern of involved joints can frequently look similar to rheumatoid arthritis, especially with MCP joint involvement. Finally, CPPD can affect the spine, and it can cause different manifestations within the spine. It can cause acute pain, stiffness, and fever that can occur in the cervical spine or the lumbar spine. It also can cause chronic stiffness in any area of the spine. Targeted treatments for CPPD, unfortunately, do not currently exist. And for patients who have osteoarthritis with CPPD, we treat them very similarly to patients who have primary osteoarthritis. Patients who have acute CPP crystal arthritis are treated very similar to patients who have an acute manifestation of gout. And so that means we use NSAIDs, colchicine, we aspirate joints, we inject joints with steroids. If patients have multiple joints involved, then we frequently will use oral steroids. As I mentioned before, even without treatment, this form of acute CPP crystal arthritis, it does tend to resolve on its own, but it takes several weeks. Patients with chronic CPP crystal inflammatory arthritis are treated similarly to patients with other types of inflammatory arthritis, but these treatments may or may not be successful in CPP inflammatory arthritis with the chronic manifestations. So we may try colchicine, methotrexate, hydroxychloroquine, or anakinra. And finally, the treatment of spinal CPPD really depends on the clinical presentation. If a patient has Crown-Dehn syndrome, which is the acute inflammatory manifestation around the spine in the neck, then patients are treated with oral steroids. Rarely, patients have chronic deposits of CPP crystals in the spinal ligaments that can be so large that they can cause spinal cord compression. And in that case, they would require surgical treatment. Thanks for listening, and we look forward to a nice discussion with the group.